A 71-year-old museum visitor chooses the corridor that feels aligned with the entrance, walks through it, and returns to the exhibit he just left. He may call that a memory failure, but the mistake also occurred while repeated turns forced his brain to update direction without useful landmarks. The first answer is that navigation is not memory alone. The brain combines head motion, vision, and body position signals to estimate where movement has carried you. Balance, orientation, spatial memory, and navigation overlap, but they are not interchangeable. A person can stand upright, yet still estimate a turn poorly. That distinction does not make the inner ear the default explanation for getting lost. It identifies one input among several that require separate assessment. In the museum case, several corridors look alike. There are few landmarks, and every turn requires the visitor to track how his own position changed. He chooses the passage that feels aligned with the entrance. The visible consequence is not forgetting an exhibit. It is arriving at the previous one. The relevant operation is path integration, updating an estimate of position and direction for movement, especially when external landmarks provide little correction. So the first correction is practical. A wrong route can reflect a drifting movement estimate, but the route error alone cannot reveal why it drifted. Inside the inner ear, semicircular canals respond to head rotation. They contribute information about turning, not a stored picture of the destination. The otolith organs contribute information related to linear acceleration and gravity. Together, vestibular signals help specify how the head moved through space. Those signals arrive alongside vision and proprioception, the information from muscles and joints about body position. Navigation uses their combined evidence, not one isolated channel. When landmarks are strong, vision can repeatedly correct the estimate. When corridors repeat and the entrance disappears, internal movement signals carry more of the update. The payoff is a cleaner model. No channel operates alone. External cues and bodily feedback can offset or amplify an imprecise heading during travel. A 2017 study tested this question with 48 adults, using objective vestibular measures and a triangle completion task designed to probe spatial navigation. The comparison included older clinic patients with measured vestibular loss, older controls, and younger controls. That grouping matters because this was a selected sample. During triangle completion, participants traveled along two guided segments, then attempted to return toward the start by estimating the missing final segment. The older patients with vestibular loss made larger distance and rotation errors than both control groups. The result concerns measured task performance, not diagnosis. That is the first evidence payoff. Objective vestibular loss accompanied worse navigation. Task accuracy in this sample. It did not establish the cause of dementia. Distance error and rotation error describe different failures. One concerns how far the person traveled. The other concerns the direction selected after turning. That separation helps researchers describe what changed without treating every miss as the same navigational deficit. A person may reduce one error by using a familiar landmark, slower movement, or better lighting. Laboratory performance does not map perfectly onto daily travel. Vision can compensate in some settings, but visual impairment can also remove landmarks. Proprioceptive changes or mobility limits can alter the movement information available. Attention matters because movement must be monitored while surroundings change. Stored route knowledge matters because a known destination can guide choices beyond immediate motion signals. These alternatives predict variation. Errors may increase when landmarks disappear, turns accumulate, walking changes, or attention is divided. No single pattern proves vestibular loss. A broader review considered links among vestibular impairment, cognitive decline, and Alzheimer's disease. Its conclusion was cautious because the evidence base remained limited and mixed. Mechanistic plausibility is not the same as clinical proof. A system can contribute to navigation without being established as a cause of neurodegenerative disease. The clinically important step is testing each claim at the level where it is made. Human studies vary in vestibular measures, cognitive outcomes, populations, and designs. That variation makes a simple causal chain difficult to defend. Selected clinic samples may contain more severe symptoms or additional health differences than the general population. 48 participants cannot establish population prevalence. The evidence correction is precise. Vestibular function contributes relevant information, and impairment can accompany worse spatial performance. But dementia causation remains unproven. Why might task errors appear? A degraded motion estimate could accumulate across turns, leaving the final heading or distance farther from the start. Yet the same final offset can arise if a person misheard instructions, walked unevenly, missed a landmark, divided attention, or misunderstood the task. A laboratory triangle removes many daily life cues on purpose. That makes one mechanism easier to study while making the task less like familiar wayfinding. Conversely, a familiar route adds memory, learned landmarks, decision points, traffic, and mobility demands. Performance there cannot isolate vestibular input by itself. The practical rule follows. Use controlled tasks to test components, then interpret real-world disorientation with the person's sensory, cognitive, motor, and medical context. For assessment, begin with the event itself. Was the problem dizziness, imbalance, a wrong turn, failure to recognize a place, or confusion about the goal? Then document conditions, lighting, landmarks, number of turns, walking speed, hearing, vision, footwear, fatigue, medications, and whether symptoms began suddenly. Separate route knowledge from movement updating. Knowing where the exit should be differs from estimating which direction now points toward it after several turns. Also separate orientation from recognition. A person may recognize the building and people around them yet remain uncertain about the direction of the exit. The assessment payoff is a better question, not a self-diagnosis. Which part of navigation failed, under what conditions, and which systems were available? Now, the boundary vestibular contribution does not mean vestibular sufficiency. Strong vision or proprioception may compensate. An impairment elsewhere may mimic the same difficulty. Dizziness is not synonymous with vestibular loss, and vestibular loss is not synonymous with disorientation. Symptoms and test findings belong to different levels of evidence. A person with normal vestibular testing could still get lost because of vision, attention, memory, medication effects, illness, or an unfamiliar environment. A person with vestibular loss may navigate familiar places effectively by using vision, learned landmarks, deliberate pacing, or another person's guidance. That rational exception matters. Compensation can protect daily performance. So laboratory impairment and everyday disability will not align perfectly in every person. The 48-person study also cannot tell how common these errors are, predict one patient's future, or establish that vestibular change preceded cognitive change. Its value is a measured comparison, not a forecast. The broader review validates caution, not dismissal. It supports studying vestibular, cognitive links while rejecting a leap from plausible mechanism to Alzheimer's causation. The corrected conclusion is multisystem. Poorer vestibular function can accompany poorer navigation, while causal interpretation still requires vision, proprioception, cognition, mobility, and disease context. Return to the museum visitor. His wrong corridor is useful evidence about the event, but it does not distinguish sensory drift from attention or memory. A useful comparison changes the conditions. Does performance improve with clear landmarks, fewer turns, slower pacing, better lighting, or an accompanying guide? Improvement under one condition can identify useful support. It still does not diagnose the underlying disorder or prove that every future route will be safe. Persistent difficulty across supported and unsupported settings raises a broader concern, but qualified professionals must interpret symptoms, examinations, and task results together. The full answer is that vestibular input supports person-centered path integration, and objectively poor function can accompany larger navigation errors in a selected sample. But navigation also depends on vision, proprioception, attention, mobility, learned environments, and disease. Disorientation therefore requires broader assessment than a single mechanism story. Vestibular rehabilitation may be evaluated for balance or dizziness goals, but the supplied evidence does not show that exercises prevent or reverse cognitive decline. Treat claims about cognition as intervention questions: which population, which therapy, which cognitive endpoint, which comparison group, and how long was follow-up. The resolved framework is simple. Motion signals contribute. Task associations, inform hypotheses, and clinical conclusions require converging evidence rather than one symptom or one study. For a routine appointment, describe concrete events where the wrong turn occurred. How many turns preceded it? What cues were available and what symptoms accompanied it? New dizziness, falls, or disorientation can have urgent causes outside this episode. Sudden or severe changes warrant prompt professional assessment rather than self-testing. For recurring non-urgent problems, bring observations rather than a diagnosis. A clinician can decide whether vestibular, vision, neurological, medication, or mobility evaluation is appropriate. A wrong turn is evidence, not a verdict. Separate movement updating from memory, then assess the whole system. Optimize the protocol, protect your brain, and I'll see you in the next dataset.